Ken Sabe. This is lunchtime, John. You know that, and you thought there would be no discussion. That's very interesting. Very interesting. No, this will be very short. I have 9 minutes, but I mean, there's very little data unless you have it and I don't know it. But so I have very little things to say really, apart from this. So I grabbed this piece of information that came out from ASH, last ASH in Orlando. So this is outcome with alternative therapy following discontinuation of ibrutinib or idelalisib. It was an oral presentation. This is on 93 CLL patients who stopped either ibrutinib or idelalisib-based therapy for any reason. Toxicity was the most common reason for discontinuation. And you can see here what they went on to after discontinuing. They went to an alternative KI, a BCL2 inhibitor, chemoimmunotherapy, or CD20 treatment. You see the numbers here, and you see the responses, which are mainly seen by giving another inhibitor, or even higher with a BCL2 inhibitor. You can see it here. Much less as expected, I would say, with chemoimmunotherapy or with CD20, even higher with CD20, which is interesting if you may, but numbers are small. Degree of response, well, mostly partial response. You can see 50% with another inhibitor, up to 69% with the BCL2, plus 7% CRs. So there's certainly quite important figures, I would say. So this would suggest on a reasonable number of patients, 93 is quite reasonable, that many patients can be successfully switched from one BCR agent to another or to something else, which is largely not conventional treatment. So that, I think, is what we have really. When I went into a bit more detail, I mean, there's the data from the venetoclax ABT199. I don't need to go into these are responses, relapse CLL. I went to look at the paper, and there's no indication, maybe somebody knows, but I didn't see it in the New England paper, whether any of these patients had received an inhibitor before. It's not stated as far as I read, so I don't know if any of these patients had received an inhibitor. But we have it here, though, from this other study. Then there's been this other paper came out in New England with this other BTK inhibitor, and these are the data, certainly very interesting. And here, in fact, there were 4 patients who had been previously treated with idelalisib, tiny bunch of patients. Response rate was very high, 100%, partial response 35, and partial response with lymphocytosis 25%. So very small figures. This slide you've already seen. This goes back, ties some issues together. It's a long follow-up of ibrutinib after 3 years, the John Bird paper in Blood, recent paper in Blood, and showing once again that 17p do well, but do less well, as also 11q. We are not talking about that, but it's intermediate. If you don't have these, you do better. So I'm saying this because clearly this goes back also to the ACMRD that we just heard. So these patients do certainly better. And this opens the issue of what we do to these patients. Because they come in, we test them, they need treatment, they have a 17p deletion. Until yesterday, if it was a fit patient, we would probably suggest a transplant. What do we do now? It's becoming certainly more difficult, particularly if you do it first-line treatment, the curves will be better. So in essence, I think in most parts of the world, the transplant not really performed any much more, at least it's declining because they do drugs. This is important because if you can cross over to another inhibitor, this means that you're buying time in any case, even with one drug, and you can maybe cross over to another drug or to a BCL2 inhibitor. So this is something I think very important, that it's not that if you lose efficacy to ibrutinib, we have nothing else to offer to a 17p patient. Maybe, we don't have data, at least I don't know the data, or crossover in these yet, but the data will come out. Certainly this, going back to what Paolo was discussing earlier, I think is a category of patients, it's outside the scope of my talk, where we should offer something more. Here really the combination is extremely important. Here we should try to induce MRD negativity. This I think is really a must, and if the subclones become important, we're talking about the 15% of patients at first-line treatment, which is not minor, and a relapse, early relapse much higher. So that is really the primary unmet need. And this is what we used to offer before the new drugs. If we had a patient, we had to stratify, did this, and we went down to a transplant. And MRD was clearly driving everything in the old days. So this is where we stand, and we stand with this even today in many parts of the world. So this is my final slide. Just some thoughts. Though the available data are certainly limited, it would appear that patients progressing after or on BCR receptor inhibitor may respond to another agonist or to other mechanism-based compounds. BCL2 inhibitor is clearly one. But I think this observation needs further confirmation on larger series of patients. But certainly the hint is that you can cross over to another inhibitor, another mechanism-based drug. Finito. Steve, you have more data?
No, I think there's just an important point to make. So if you go back to the first slide, which really is the largest report so far with 93 patients, but the point is that so the majority of these patients probably are patients who had prior idelalisib, and they came off because of toxicity, and then they got ibrutinib. That's your first column, right? I think it's incredibly important to make a distinction between going on another kinase inhibitor because somebody was intolerant of the prior one or they were resistant. And this data does not distinguish between the two, right? Right, and so, you know, this, I don't think it's all that helpful in answering a relevant clinical question for us, because of course they're going to respond to ibrutinib if they had transaminitis or whatever, colitis on idelalisib and came off of it. Yeah. That's no surprise. What we really want to know is, are you going to respond to one if you've progressed on the other? And the BCL2 folks, those are the patients who are on a trial for patients who have had Idela or ibrutinib, but again, it includes patients who are both intolerant and resistant. So, you know, these numbers get out there and we get these impressions, but we can't really apply them to our individual patients without more clarity.
I mean, there are very few data, because luckily patients respond. So we don't have clear information. If you lose response, you can move to another one. That data is loose. On the other hand, it's practically useful too, because then it puts doctors, hematologists in a good position. Say if a patient has toxicity to one of the drugs, he or she can be shifted to another one, and with high likelihood of responding, which is obviously positive.